Hi everyone, we are back with another session with Hirad EP. Please subscribe and click like if you find these videos helpful and if any of points that we mentioned these videos were added to your knowledge. So we're going to continue to review the latest Afib guidelines that published in 2023, and this is going to be part 3 of that. And we're going to go over the anti-arrhythmics that can be used for long-term management of atrial fibrillation and maintaining patients in sinus rhythm. So basically rhythm management, mostly as an outpatient setting that we're going to talk about it. So again, 2023 guidelines, we're almost going every week and reviewing important aspects of the guidelines. All right, let's start. So let's talk about these medications, the rhythm medications that we're talking about. So if the patient is keen to get a procedures like atrial fibrillation ablation, we usually recommend that sometimes as a first choice. But if the patient is not a candidate, is declining to get a catheter ablation or prefer anti-arrhythmic therapy, we start these anti-arrhythmic therapies. Basically, there are 4 or 5 major medications. There are a few that is not mentioned in the guidelines that we can use for treatment of sinus rhythm and maintaining the patients, keeping the patient in sinus rhythm. One is amiodarone, the second one dofetilide, the class 1C flecainide and propafenone, and the dronedarone or Maltac, and the last one is sotalol that we can use for maintenance of sinus rhythm. So it's very important to know that the way we choose these medications based on their side effects and also what is going on with the patient. For example, if the patient has ejection fraction less than 40%, LVF less than 40%, the 2 medications on top of the list with the class 2A recommendation is dofetilide and amiodarone. But if you don't have any myocardial infarction history, if you don't have any scarring in your ventricle, or you don't have a structural heart disease, you can use flecainide and propafenone for the long-term maintenance. Last week in the video we mentioned that we usually like to have to take these medications or give this medication to the patient at least once in a monitor setting and see the patient's tolerated or how it goes. And also for these type of medication, we always like to have adding beta blockers, calcium channel blockers if it's allowed, if it's not contraindicated, to prevent the chance of one-to-one atrial flutter, atrial flutter conversion if the Afib convert to flutter. Now, the other important things to remember is we can medications like dronedarone that we can give as an outpatient, but you need to make sure the patient doesn't have any history of decompensated heart failure or severe LV dysfunction. And we'll get to some of these data in a few slides away from that. So that is important, that make sure the patient doesn't have history of heart failure and also no history of severe LV dysfunction. And in patients that have significant normal, if they don't have a significant baseline QT interval prolongation, if you don't have issues with low potassium and low magnesium, you can start them on TKC or dofetilide. It is important that you know that we basically admit these patients for 3 days loading, and we look at the patient's QT and see if the patients meet the criteria to continue the rhythm medication. So there's a problem with the TKC and dofetilide is we need to load them, and when the patient needs to be admitted. Of course, we need to monitor the patient's potassium, magnesium, and make sure the kidney function is still normal, is not abnormal, because there is a high risk of torsade if the kidney function worsen while you're taking dofetilide. And finally, the last 2A recommendation is for low-dose amiodarone, like 100 to 200 milligrams. Basically, amiodarone provides good efficacy, but the problem with amiodarone is side effects. And a lot of patients, up to 10 to 15%, might get a hypothyroidism, and the hyperthyroidism also is common. And then you can have a lung disease and liver disease that comes with amiodarone. And lastly, the class 2B recommendation is for sotalol. Same as a TKC/dofetilide. For sotalol also we need to admit the patient, 3 days of dosing, and make sure the QT is appropriate, make sure the kidney function is appropriate, and also electrolyte needs to be in normal range. Now the problem with sotalol is, especially with the patient with heart failure, they might get additional beta blocker effect because sotalol has a beta blocker effect as well. So they might get hypotensive, they might get bradycardic when you add beta blockers on top of it, sotalol. Now also there are some data that sotalol can increase risk of mortality in patients with low ejection fraction. That's the reason is class 2B recommendation, and it's kind of at the last resort if you see in the algorithm as an option for maintenance of sinus rhythm. All right, so let's get to this important. This is very interesting and important algorithm. I think is very helpful to remember what to do, what not to do. And so basically, as you see, if the patient comes with atrial fibrillation, the first and most important thing is what is going on. If the patient have normal structural heart, normal LV function, no MI, no stroke heart disease from other stuff, so you can use all of these medication. You can use dofetilide, you can use dronedarone, you can use flecainide, you can use propafenone. And because amiodarone, although it's more effective but comes with a lot of side effects, is on the next step after these four medications. So dofetilide, dronedarone, flecainide, and propafenone 1C, and this from the class 3 can be used for the patient with normal LV function, no heart failure issues, no prior MI, no significant stroke heart disease. And sotalol, as I mentioned, because of the some meta-analysis shows increased mortality, especially in patients with heart failure, reduced ejection fraction. They put it as 2B at the end, and if you don't have any other of these options available or the patient is not tolerating, you can go to the sotalol. Now, if you have MI, if you have structural heart disease, if your ejection fraction less than 40%, then you have two groups that you need to think about. If the patient has recently compensated heart failure and is class 3 or class 4 especially, then you cannot use dronedarone. Maltag is off the list. And if doesn't have these heart failure, and you can still consider dronedarone. Usually when the patient has low ejection fraction, in my opinion, I don't go over and I don't try dronedarone. I'll go down to this arm of taking amiodarone or dofetilide. So if your ejection fraction less than 40%, if you have a heart failure, you have significant myocardial infarction, then I go after these two as a choice of medication for maintenance of the sinus rhythm. Now, the second is sotalol 2B. And the last that you need to remember, you should not use flecainide, propafenone, class 1C for patients with any history of structural heart disease. Now, there are some new data that shows in some category of patients, if you don't have active ischemia, maybe you can use these medications, but that's for future. For now, based on the guidelines, do not use class 1C medication if you have history of MI, cardiac arrest, issues with structural heart disease, and ejection fraction less than 40%. And the last part that we want to talk about is the data, the trials that focus on effectiveness and safety of different of these rhythm medication that we talk about. One by one, each slide is for each of these medication. FLEC-SL is short-term versus long-term anti-arrhythmic drug treatment after cardioversion of AFib trial. This was the trial that showed flecainide can decrease episode of paroxysmal AFib significantly comparing to placebo. And then, as famously in CAS1 and CAS2 trial, they look at flecainide and other class 1C family and have found that mortality significantly increase in patients with a recent MI and low ejection fraction. CAS trial, to look at the cardiac arrest and use propafenone, they found the same stuff. So basically, that's the reason. Strongly recommended to not use flecainide, propafenone for patients with a history of MI, structural heart disease, or ejection fraction less than 40 to 50%. And now we can talk about Maltag here too. So Maltag is also supported with a lot of multiple randomized control study and combined analysis. And this is one of them, Hirad and Adonis, they put it together and have found significant improvement in controlling atrial fibrillation and decreasing recurrence of atrial fibrillation when the patient is taking dronedarone versus placebo. And the reason that we are prohibited to give it the Ronduron to patients with a class 3 or 4 heart failure or recent decompensated heart failure is because of this trial Andromeda that they thought it will help the patient with moderate to severe heart failure, and they found the opposite results. And then dofetilide ticasin, I think one of the trials that I'd like you guys to look if you're interested to know more is Sapphire D, symptomatic AFib investigative research on dofetilide. That also shows significant number of patients receiving dofetilide 500 microgram twice daily will have recurrence in incidence of atrial fibrillation. Actually, I like dofetilide for patients who have significant scar, persistent AFib type, and they respond very nicely to ticasin or dofetilide. The only problem is admission for 3 days and looking for, making sure the patient doesn't get prolonged QT. And one of the most important medication that you need to remember is amiodarone that we give all the time. So SAFE trial, also CTAF Canadian trial, AFib showed that amiodarone is very strong and superior to sotalol. As you see, significantly decreased recurrence of atrial fibrillation when was compared to sotalol and also placebo. And lastly is the sotalol that, as you can also see, the sotalol in safety trials show efficacy better than placebo, but was worse than amiodarone. And unfortunately, we have this meta-analysis of 5 randomized study, over almost 2,000 patients that report sotalol can be associated with increased all-cause mortality. We recently have IV sotalol form in the market that can decrease the duration of loading, and also, there are some data that patients with advanced heart failure might not be a great choice to take sotalol for maintenance of their atrial fibrillation. So thank you again, guys, and please stay tuned for next week, and have a nice rest of month of January. Thank you.